My name is Doreen Rodo, and I have over 25 years of experience in long-term care. Today, I'd like to share some of that knowledge with you and give you some practical information on how to be a long-term care RDN or DTR. The objectives are to describe best practices for an RDN or DTR in a long-term care setting, discuss comorbidities and how they affect nutritional care, describe the charting timetable, and to understand the nutrition care process for long-term care. As a way of standardizing nutrition care, the Academy of Nutrition and Dietetics developed the Evidence Analysis Library. Here's how it works. A group of experts determines a nutrition question, they review supporting documentation, and provide a graded conclusion statement. Grades are good evidence, fair evidence, limited, expert opinion, and not assignable. I wanted you to know about this because I will be referring to the EAL during this presentation. This slide shows the causes of nutrition deficits. Many elderly have decreased taste, smell, mobility, and the reduced ability to prepare food. Many are also on a budget. On top of that, they may have one or more illnesses that affect nutrition intake. If they have psychological disorders, that also may alter meal intakes. Here's what the EAL has to say about diabetes. For those on a fixed insulin dose, a consistent carbohydrate intake can improve glycemic control. For those with low literacy who have type 2 diabetes, portion control or making healthy food choices may be more appropriate than a strict carbohydrate controlled diet. The ratings for these are fair. Fair means the evidence consists of results from strong studies, but there is some uncertainty about the conclusion. The EAL also reports that MNT encounters can significantly reduce HbA1c by 0.3% to 2% in adults with type 2 diabetes and by 1% to 1.9% in adults with type 1 diabetes during the first 6 months. The evidence for MNT is rated as strong. Here's what the American Diabetes Association says about target A1Cs. If you're healthy and have few coexisting chronic illnesses, your cognition is intact, as well as your functional status, your target A1C should be less than 7.5. However, if you are a complex individual with multiple coexisting chronic illnesses, ADL impairment, and mild to moderate cognitive impairment, your A1C can be less than 8%. For very complex individuals, those in long-term care or at the end stage of a disease, or with moderate to severe cognitive impairment and 2 or more ADL dependencies, the A1C can be less than 8.5%, and that is why we are able to liberalize diets in long-term care. We do get residents with congestive heart failure. I recommend a low-salt diet with a fluid restriction, especially if they are having edema of varying degrees. However, there is an increase in noncompliance, especially with the fluid restriction. It's very hard to get someone to limit their fluid intake, but it works better if they truly understand it. One patient I had who spoke Russian didn't understand why I needed him to limit his fluids. His son came in to translate for him. After that, he was more compliant because he understood the restriction. Many with congestive heart failure are on daily weights, and the facility usually has an order to notify the MD of a 2-pound increase between weights or a 5-pound increase in 1 week. A resident can go into congestive heart failure very quickly, so I pay attention to the daily weights so I can assist the nursing department with this process. The goal for those with CHF is to improve symptoms. The EAL reviewed several studies and rated the following studies as fair: a sodium intake of 2,000 to 3,000 milligrams per day, protein, at least 1.1 gram of protein per kilogram to prevent catabolism, with a range of 1.1 to 1.4 gram per kilogram, and a fluid intake of 1 to 2 liters per day. Use your judgment when assessing nutrition needs for those with kidney disease. The goal is to prevent and treat undernutrition and to correct mineral and electrolyte disorders, as well as to minimize comorbidities. The EAL suggests 0.6 to 0.8 grams of protein per kilogram of body weight per day for those with a GFR of less than 50. Evidence for these calculations is strong. Dialysis residents need extra protein with limited salt and potassium. Many receive a phosphate binder. I have found that they don't always take their binder with meals. They may take it too early or too late, so if you notice that the phosphorus is high and they're on a binder, check with nursing staff to make sure that it's given with food and snacks. We also communicate with the renal RD via a notebook or a phone call to ensure continuity of care. I will tell you this, last time I had a state survey, they did ask me for documentation to prove that I spoke with the renal dietitian. Dysphagia is a widespread problem in the elderly. They are at increased risk due to having many factors that lead to swallowing difficulties. Some of these are a diagnosis of stroke, dementia, pneumonia, Parkinson's disease. The slide shows the effects of dysphagia. It can cause aspiration pneumonia, which may lead to dehydration and malnutrition, which may lead to muscle breakdown and an increase in infection and decreased function. Dysphagia is many times underdiagnosed, so RDs need to be aware of this to make sure our elderly are getting optimal care. One thing I like to do is to ask new residents if they're having any trouble chewing or swallowing. If they are, I usually refer them to the speech-language pathologist. What to look for with dementia. Residents will forget to swallow and pocket their food. This causes prolonged mastication, which can lead to aspiration. Take note of this so you can make sure that your residents are on the best texture. You can downgrade a resident's diet to a softer texture until the speech-language pathologist can see them. Comorbidities and pressure sores magnify nutrition deficits. If someone who is a diabetic has a pressure sore, we sometimes shift our focus to healing the pressure sore instead of worrying so much about their diabetes. For example, if they are on a diabetic, heart-healthy diet, we might liberalize it to a consistent carbohydrate diet to ensure good intakes. Diet liberalization should be individualized. However, you should be careful for those with unstable diabetes, those with congestive heart failure who are eating 100%, and residents with chronic kidney disease without dialysis. I did have one resident with chronic kidney disease who stopped eating. I liberalized his diet and he started eating 50% of a regular meal. I don't always liberalize diets with short-term rehab patients. I generally speak to them about their diet and give them good information about the benefits of following a stricter diet and then allow them to make the decision. The EAL states that an approach can be the liberalization of diets, as research has not demonstrated the benefits of restricting sodium, cholesterol, fat, and carbohydrate in older adults. Diet compliance. We do have residents who choose not to follow a therapeutic diet. Our goal is to balance the residents' wishes with therapeutic needs. An example would be a diabetic who wants a regular dessert. You could try to negotiate a regular dessert 3 times per week. If you do, make sure you put this on their care plan and write a note that the resident has agreed to this. One of the facilities that I worked at received a violation for not honoring a resident's wishes. She wanted a regular dessert daily, but the facility would only give her one once a week. It's important that you understand that an alert and oriented resident has the right to choose whether or not to follow their diet. It's similar to what a person would choose if they were at home. The State Operations Manual from the Centers for Medicare and Medicaid Services gives long-term care facilities guidelines to follow. One of them is a resident or resident representative has the right to make informed choices about accepting or declining care and treatment. Our goal as a health professional is to give them the information that they need to make an informed choice. Before we begin, I want to mention a little bit about the nutrition care process that was adopted in 2003. This process ensures that RDNs and other nutrition professionals are providing individualized care to all. The first step is the nutrition assessment or collecting the information. Then we have a diagnosis where we identify a specific problem. After that, there's the interventions, and this is the plan to alleviate the problem. The fourth step is monitoring and evaluation. We want to see how the resident is progressing towards the goal. I tell you this because there are 4 steps in the nutrition assessment process for long-term care. The steps that we just discussed from the nutrition care process also occur within the nutrition assessment process for long-term care. The first one is the nutrition assessment, followed by the care plan and the MDS or minimum data set, the fourth thing being the resident care conference. We will discuss each of these steps in the next few slides. All new residents receive an initial MDS assessment within 5 days. Those who are on Medicare also get a 14-day, 30-day, 60, and 90-day assessment. This is a great way to monitor the residents because we are looking at them at regular intervals and can easily note changes such as a decline in meal intake and weight loss. Those who are not on Medicare are followed by monitoring weekly weights, as all new residents have weekly weights taken times 4 weeks. I may do some interim notes to identify a weight loss or a pressure area. All residents get a quarterly review after 90 days and annual assessments every year. I'm sure you're all familiar with what's on the nutrition assessment. The goal is to identify nutrition problems and formulate a plan. I usually note ideal body weight, but I find that I rely on usual body weight much more often. I might also compare these to the hospital weight. We also look at labs, intake, skin issues, and medications. The goal is to formulate a nutrition plan of care after completion of the nutrition assessment. In 2012, the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition, or ASPEN, agreed that a person could be considered malnourished if they had at least 2 of the following: inadequate energy intake, weight loss, decrease in muscle mass, decrease in subcutaneous fat, localized or general fluid, a decline in functional status. The Academy of Nutrition and Dietetics put out a nutrition-focused physical exam pocket guide to assist health professionals in completing the nutrition assessment. The booklet gives categories for nutrition: severe malnutrition, mild to moderate malnutrition, and well-nourished. It would be optimal if RDNs and health professionals had time to check all the criteria in the book. However, time is usually limited when doing an assessment, so listed below are a few quick parameters to assess. However, there are many more. Indications for undernutrition. A hollow or depressed orbital region indicates subcutaneous fat loss. A depressed temporal region indicates muscle loss. Prominent visible scapular bones and depressions between the ribs indicate muscle loss. Significant weight loss of 5% in 30 days, 7.5% in 90 days, and 10% in 180 days. Less than 50% of a meal intake for greater or equal to 5 days, reduced hand grip strength, and pitting edema in lower extremities. When I'm speaking with the resident, I look for signs and symptoms of malnutrition, such as prominent scapular bones, the depression in the temporal region. I discuss meal intake with them and whether or not they've had a significant weight loss. I put all this information together when completing the nutrition assessment. I want to show you what some RDNs are actually doing in practice. After the ASPEN guidelines came out in 2016, the dietitians at the hospital where I worked came up with a guideline for stressed individuals. We used actual body weight for those with a BMI less than 30, and we multiplied this by 30 to 35 to calculate calorie needs, and by 1.25 to 1.5 grams to calculate protein needs. We used ideal body weight for a BMI greater than 30, thus multiplying ideal body weight by 30 for calorie needs, and by 1.5 to 2.0 grams of protein per kilogram ideal body weight. The Nutrition Care Manual suggests 1.2 to 1.5 gram of protein per kilogram for stressed older adults, which is similar to what we use for a BMI of less than 30. The important thing to remember, though, is to use your clinical judgment when assessing nutrition needs. Skin integrity is one of the key factors that affect nutrition status. If renal function is poor, even though they have a skin issue, being moderate with protein is the key. We need to monitor these individuals carefully. Evidence does not definitively support any specific dietary supplementation, such as vitamin C and zinc, unless the resident has a specific vitamin or mineral deficiency. You may see vitamin C and zinc being ordered in long-term care, so you need to use your clinical judgment to see if you want to keep the vitamin C and zinc. Many RDNs are opting to add a multivitamin with mineral instead of C and zinc, just as a precautionary measure. We want to monitor those with pressure sores monthly or more frequently, depending on the severity. The National Pressure Ulcer Advisory Panel, NPUAP, suggests that we use 1.25 to 1.5 grams of protein per kilogram body weight for adults with pressure ulcers that are at malnutrition risk. One way to monitor pressure areas closely is to have a weekly skin and wound meeting or a PAR, patient at risk meeting. This can include the RDN, RN, wound nurse, social worker, certified dietary manager, administrator, and in some places, even a doctor. Individuals with wounds or weight loss that is not improving are discussed, and we as a team decide if we need to change the interventions. Albumin and pre-albumin have recently been questioned as viable nutrition markers. The State Operations Manual states that serum albumin may help establish prognosis, but is only sometimes helpful in identifying impaired nutrition or guiding interventions. The International Dietetics Nutrition Terminology (IDNT) reference manual states that lab values might be helpful in observing nutrition over time in combination with other nutrition markers, such as weight gain and nutrient intake. Davis and colleagues said that albumin and pre-albumin, transferrin, retinol binding protein are a reflection of the acute phase response and do not represent nutritional status in an ICU setting. Putting this all together, I suggest being careful with recommending albumin and pre-albumin, and also when using them to determine nutrition status. If possible, complete a nutrition-focused physical exam before making any recommendations. Evaluating significant weight loss or gain. This is the standard: a 5% gain or loss in 30 days, 7.5% in 90 days, or a 10% gain or loss in 180 days. When I'm doing a quarterly review, annual, or a weight change, I look at the weight at all of those intervals. If it is significant, I speak with nursing, the resident, and if possible the family to come up with appropriate interventions, which I document in my progress note and put on the resident care plan. The first thing I do when assessing weights is to look to see if there's any edema. I check to see if they're receiving diuretics and if the diuretic was changed. I look at other medications as well. In many cases, I see a weight gain with prednisone and then a loss when it is tapered. Insulin and oral hypoglycemic agents may affect weight, causing a gain. Sometimes, when a weight loss is unexplainable, I look at the medication Synthroid. I have seen some lose or gain weight if they are on this med and their thyroid level is off. So if they haven't had a TSH level T3 or T4 in a while, it may be a good idea to recommend one at this time. Nutrition interventions should be individualized. However, if possible, try food first. An 11-week randomized controlled study of 121 nursing home residents revealed improved nutrition and function with a 3-step approach of chocolate homemade supplements, group exercise, and oral care. Beck and colleagues determined that multifaceted nutritional interventions among nursing home residents had a positive influence on nutrition and function. Try food first, but sometimes supplements are a good option, especially if the resident is a better drinker than eater or has had a large weight loss. You could also try weekly, bi-weekly, or daily weights to monitor that patient closer. Request adaptive equipment. You may get OT involved. You could ask for assistance with meals to ensure good intakes. We could get the speech-language pathologist involved if there is a suspected chewing or swallowing problem. We could get to dental consult if there is mouth pain related to dentition. We could do meal rounds. Perhaps we should offer a sandwich on the side or a snack after the meal. Or we can find out during this time if there are any additional food likes and dislikes. We could recommend a calorie count. I like to use this as a last resort because honestly it's difficult for staff to fully complete them, which makes it hard for me to assess. But the most important part is to see what the resident is actually doing at meals, and this may determine your intervention. Our goal with dehydration is to improve fluid intake in the elderly. We may discontinue meds that affect fluid balance, have hydration stations so residents are reminded to drink, give an extra 120 milliliters of water at each med pass, and to refresh water pitchers regularly. The resident care plan is step 2 in the nutrition assessment process, and it includes the problem or PES statement, goal, and approaches. You should update the resident care plan after any change. Resident care plan rules: clearly state the problem, have a measurable goal, and realistic approaches. Given someone who doesn't drink milk, a shake may not be a realistic approach. Talk to the resident or staff to find appropriate choices for that individual. In a later slide, I will show you a sample care plan. Let's look at our sample patient. What would you recommend? What would the care plan look like? Mrs. Smith is a 90-year-old diabetic with a URI. She has indentation at her temple region. She has a high BUN, sodium, and potassium. She has a stage 2 open area on her coccyx. She has difficulty chewing. Her diet is mechanical soft, no concentrated sweets. She eats 25% of meals, and this is a decline as she had been eating 50 to 75%. She has had a weight loss. She was 107 pounds in December of 2014. 1 month later, she was 100 pounds. Take a moment to think about what you would do. The problem or PES statement is inadequate energy intake as evidenced by significant weight loss of 6.5% in 30 days due to PO intake less than 50% of estimated needs. The goal is weight will be 100 to 110 pounds and meal intake will increase to 50 to 75%. Approaches are a no concentrated sweet mechanical soft diet, 3-ounce house diet supplement BID, fortified cereal QAM, a plate guard at meals, weekly weights, restorative dining at meals, a sandwich at HS, 120 milliliters extra fluid Q-shift, multivitamin with mineral, and 30 milliliters liquid protein QD. The problem is actually a PES statement and the approaches are the interventions or step 3 in the nutrition care process. Step 3 in the nutrition assessment process is the MDS or minimum data set. The minimum data set gives us information for reimbursement to the government for those who are on Medicare and Medicaid, but we do fill them out for all residents. Dietitians generally fill out the K section of the MDS. Here is a sample. Dietitians have to answer swallowing issues, height, weight, planned or unplanned weight loss or gain, as well as nutrition interventions such as IVs, tube feedings, therapeutic and mechanically altered diets. Assessment reference date. 7 days prior to the ARD is the observation period. It's during this time that we assess for swallowing issues, weight changes, and nutrition interventions. If any of these triggers occur within the observation period, then we code for them. However, if a resident was having swallowing issue and a puree diet was given solving the problem, we would not code for a swallowing difficulty unless the swallowing issue was unresolved during the 7-day look-back period. When coding the MDS, we need to look at the most recent weight in the 7-day look-back period. For example, if the assessment reference date was May 23rd, we would take the weight closest to May 22nd, which might be the monthly weight for May on the 5th, or perhaps a weekly weight on the 20th or 21st. We would also look at their diet and whether they were on a tube feeding in the 7-day look-back period. If they were on IVs on May 20th, then we would code for them, but if they were on them on May 5th, we would not code for them. Also, you must sign the MDS after the ARD date. I like to sign them the day after if possible. You have approximately 1 week after the ARD date to sign the MDS. I have been completing MDSs for over 10 years, and I didn't know that if a supplement is given for protein-calorie malnutrition, then it can be coded as a therapeutic diet. So I guess you could say that I learned something from preparing this presentation. Here is a sample of Section K MDS for Mrs. Smith. K0100 was coded as none of the above, as she did not exhibit any swallowing issues. Her height was 62 inches and her weight was 100 pounds. This was a significant unplanned weight loss, so K0300 was coded as 2. Yes, not on a physician-prescribed weight loss regimen. K0310 was coded as 0 as there was no weight gain. K0510 was coded as C and D, a mechanically altered and therapeutic diet. Step 4 in the nutrition care assessment process is the resident care conference. The family, resident, MDS nurse, charge nurse, social services, recreation, and the RDN or dietary manager all attend. It's a great way to get more information from the residents and family. Also, it's a good time to discuss discharge plans for short-term rehab patients. RDNs make recommendations on a daily basis, so it's your job to make sure that these recommendations are written and implemented. If you recommend a supplement that isn't ordered, then there could be a weight loss or pressure injury that could have been prevented. This would be a violation on the state survey. Follow-up is the 4th step in the nutrition care process. Answer this question. How often would you follow up on Mrs. Smith? Pause the video to consider your answer. If you answered weekly, you are correct. In 2016, CMS came up with several final rules to improve the care and safety of 1.5 million residents that reside in long-term care facilities. One of the rules was to allow dietitians and therapy providers to write orders in their area of expertise when a physician delegates the responsibility and state licensing allows. Currently, I'm able to write orders in some of the facilities where I work. This makes follow-up very easy because I do not have to check back the next day to see if the order was written because I know I've already written it. Other things to think about. I once had a resident with a soy allergy. I obtained soy-free bread, but she didn't like it. She was unhappy with meals and she was getting chicken and fish with rice at every lunch and dinner. We obtained soy-free mayonnaise and completed an individualized menu. A couple of weeks later, when I spoke to her, she was happy with the meals and her intake had increased. Also, religious and cultural needs should be addressed. The biggest ones that I see are fish on Fridays or no ham and pork products. Studies have shown that the environment can play an important role in improving the meal intake of the elderly. Facilities can try alternate meal delivery styles, a home-like atmosphere, improved lighting, relaxing music, or high-contrast tableware, especially for those with dementia or Alzheimer's. In summary, we can improve the nutrition care of the elderly by individualizing their nutrition assessment and plan, and by getting input from the resident or representative before making changes to the plan of care. We should provide timely follow-up and modify the plan of care as needed. Finally, we must communicate with other staff to improve the quality of care provided and to promote an improved quality of life and dignity. That concludes the presentation. I hope that you have learned something from your look into long-term care today. For more information, join the Facebook group Dietitian Mentor and visit www.dietitianmentor.com.